ಆ ಪಾಪ ಶಿವ್ ಬಿರಾದರ್ ನೋಡ್ರಿ ಮೇಡಮ್, ಏನು ಕ್ಯಾನ್ಸರ್ ಆಯ್ತಂತ ಮೇಡಮ್.
ಆಪರೇಟ್ ಆಗಿದ್ದು ಮಾತಾಡೋದು ಬರಂಗಿಲ್ಲ. ಈ ಕಿಮೋಥೆರಪಿ ನಡೆದದು, ಕಿಮೋಥೆರಪಿ ರೇಡಿಯೋಥೆರಪಿ ನಡೆಸ್ಯದ
ಎಷ್ಟು ವೀಕ್ ಆಗ್ತೈತೆ ಮೇಡಮ್ ಬಾಡಿ ಎಲ್ಲ.
ತ್ರಾಸ ಆಗ್ತದೆ ರೀ. ಇದ್ರದ್ದು ಅಪ್ ಅಂಡ್ ಡೌನ್. Good morning.
Good morning, ma'am.
Okay, last class I wanted to start this GI secretion, but there was an internet crash, so that's why I left 15 minutes early. So today I will start GI secretion. It's one of the long question, very important long question, HCl. So I have prepared these slides with diagram. Most of diagram is there. If you want, I will later on I will give you slide. Is it okay? Can you hear me?
Yes, ma'am.
Okay. All of you know about structure of stomach, I hope. In anatomy it is over. No response. Stomach is over?
No, ma'am.
No.
No.
Okay, I will tell about the structure of stomach in basic introduction. It is a J-shaped. It has got two ends, cardiac and pyloric. Two sphincters, LES, pyloric sphincter. Two curvatures, lesser curvature, greater curvature. Three parts, fundus, body, pyloric, antrum. Then incisura angularis. Notch in lesser curvature marks antrum. You can see here fundus, pylorus, antrum. This is a greater curvature. This side is a smaller curvature. And this duodenum, this is cardiac end. This is a body. So this is the anatomy of the stomach. It is a J shape. It has got two ends. One is cardiac, another is pyloric. It has got two sphincters, LES, pyloric sphincter, two curvatures, lesser curvature, greater curvature, three parts, fundus, body, pyloric antrum, then incisura angularis, notch in lesser curvature, marks antrum. What is its microscopic appearance or structure? So, outermost is serosa layer. It is the outermost. Second, muscular layers. It has got three layers. Muscular layer. It has got three layers. One, outer longitudinal. Next, middle circular. Then inner oblique. Only at cardiac and fundic area. Inner oblique only at cardiac and fundic area. Then myenteric plexus between outer and middle. Myenteric plexus between outer and middle. Third one, submucosal. It is a connective tissue plus lymph node, lymph vessels plus blood vessels. Connective tissue plus lymph vessels plus blood vessels. Mucinous plexus between second and third layer. Then mucosal. Mucosal, it has got rugae. Rugae there is a folds of mucosa. Folds of mucosa appear on empty and disappear on full stomach. It appears on empty and disappears on full stomach. Then gastric pits, minute openings on surface of mucosa. Minute openings on surface of mucosa. 3 to 7 gastric gland open into pit. 3 to 7 gastric gland open into pit. Mucosal barrier. It is a 0.2.5 mm protects from hydrochloric acid. Mucosal barrier 0.5 to 2.5 mm protects from HCl. It is a diagram showing glands in the mucosa of the body of the stomach. You can see this diagram. Gastric glands, 4 cells. There are 4 cells, parietal or auxantic cells. That is a HCl plus intrinsic factor. Chief or zymogen cells. Chief or zymogen cells. Enzymes. Mucus cells. They are mucus. Enterochromaffin cells. Histamine. Enterochromaffin cells. Histamine. It is shown in diagram. Red color marking is mucous cells. Green color, it is showing parietal or auxantic cells. Then blue color, chief cells or zymogen cells. Gastric glands diagram here showing structure of stomach. Structure of stomach. What you are showing in between, that is the gastric glands. Fundus plus body, long and straight. It is a fundus plus body, fundus area plus body. It is a long and straight. Pylorus plus cardiac, short and tortuous. Gland has mouth, isthmus, neck, body, fundus. In arrow mark you can see it has got mouth, red color marking is showing, isthmus, blue color marking, neck with black color, body with green or fluorescent, fundus with yellow color. So there are 3 types of gastric glands. 3 types of gastric glands. Number 1, auxantic gland. Auxantic gland in fundus plus body. All 4 types cells, both acid plus enzymes. Then cardiac gland. In cardiac, mucus plus few chief cells, soluble mucus plus enzymes. Then pyloric gland. In pyloric, mucus plus G cells, mucus plus gastrin. It has got 3 types of gastric glands. One is auxantic gland, then cardiac gland, then pyloric gland. Nerve supply. Sympathetic, parasympathetic, local plexus. Sympathetic T4 to T10, cilia, ganglion. Relaxation muscle plus contraction of sphincters, plus blood vessels. Parasympathetic dorsal nerve of vagus, that's the floor of fourth ventricle. Dorsal nerve of vagus, floor of fourth ventricle, right vagus, then posterior surface, left vagus, anterior surface. Synapse with meandric plus Meissner's. Postganglionic supply to the gland. Contraction of muscle plus relaxation of sphincter. Sympathetic T4 to T10, celiac ganglion, relaxation muscle plus contraction of sphincters plus blood vessels. Parasympathetic dorsal nerve of vagus, there is a floor of fourth ventricle, right vagus posterior surface, left vagus anterior surface, synapse with meandric plus Meissner's plexus, postganglionic supply to the gland, contraction of muscle plus relaxation of sphincter, local plexus coordinated motor, that is a peristalsis movement. What are the functions of stomach? Main functions, you know that storage for 2 to 3 hours, digestive, proteolytic by pepsin, mechanical churning and grinding, that is a chyme. Intrinsic factor for absorption of vitamin B12, maturation factor for erythropoiesis. For absorption of vitamin B12, maturation factor for erythropoiesis. Deficiency of vitamin B12, pernicious or macrocytic anemia. Then its function is bacteriolytic, that's the HCl. Absorption, water, alcohol, other things. Ferric to ferrous by HCl, oxidized. Reduced to ferrous by ascorbic acid. Gastrin for gastric and pancreatic secretion. If they will ask for 3 marks functions of stomach, you just mention this much. Effect of gastrectomy, that is a removal of stomach. That is a dumping syndrome due to lack of storage. Hyperglycemia leads to insulin secretion. Hyperglycemia leads to insulin secretion. Excess of insulin in absence of food causes hypoglycemia. Infection prone, then pernicious anemia, iron deficiency anemia, protein digestion not affected. We will come to the composition of gastric secretion. Composition, function, mechanism, regulation, applied physiology. It is for the long question. Composition, volume 1.2 to 1.5 liter per day. It is a continuous. Maximum at meals, minimum at sleep. Specific gravity 1.002 to 1.004. pH 0.9 to 1.5. It is a highly acidic. So gastric secretion. Liquid, that is a water 99.45%. Solids 0.55%. In solids, inorganic and organic. I will see first inorganic, sodium, potassium, calcium, chloride, bicarbonate, HCl. In organic, again in mucus, soluble, insoluble. Next, intrinsic factor, then enzymes, pepsin, gastric secretion, liquids, that is a water 99.45%, solids 0.55%. In solids, it has got inorganic and organic. In inorganic, sodium, potassium, calcium, chloride, bicarbonate, HCl. Mucus, soluble and insoluble. Intrinsic factor, enzymes, pepsin. We come to the mechanism of HCl secretion. With this diagram, helpful diagram, you just see parietal cell, that is the intracellular canaliculi. pH 0.87 compared to plasma 7.2, 7.4. It is a active energy expenditure. It is a isotonic 150 milliequivalent of hydrogen and 150 milliequivalent of chloride per liter. It is a isotonic 150 milliequivalent of hydrogen and 150 milliequivalent of chloride per liter. It has got two steps: secretion of hydrogen into lumen, secretion of chloride into lumen. You can see here secretion of hydrogen into lumen, secretion of chloride into lumen. So hydrogen secretion in parietal cell, hydration of carbon dioxide in parietal cell, CO2 from plasma or metabolism of cell. You can see with red color arrow, carbon dioxide from plasma or metabolism of cell in presence of carbonic anhydrase. It will convert to H2CO3. By carbonic anhydrase, carbon dioxide plus H2O, it is H2CO3, H plus HCO3. By a hydrogen potassium ATPase pump. By hydrogen potassium ATPase pump. That is a proton pump. It is important. Hydrogen potassium ATPase pump or proton pump. There will be a hydrogen secretion into lumen. So this hydrogen secretion of chloride ion into lumen, active transport of chloride and HCO3 from blood capillary to cell. Active antiport, sorry, not transport, it is a antiport of chloride and HCO3 from blood capillary to cell. Passive into lumen. Chloride plus hydrogen, that is the HCl. Secretion of HCO3 into blood. Na plus HCO3, that is the NaHCO3. Passive water movement into lumen. Passive water movement into lumen. Postprandial alkaline tide. Postprandial alkaline tide. Prandial means food ingestion, tide means wave. For each hydrogen secretion, one chloride in lumen and one HCO3 in blood. For each hydrogen secretion, one chloride in lumen and one HCO3 in blood. Food in stomach stimulate to hydrogen secretion. Plasma pH alkaline. Kidney compensatory excretion of excess HCO3 in alkaline urine. So immediately after food ingestion, there is a transient increase of alkalinity on blood and urine. So immediately after food ingestion, there is a transient increase of alkalinity in blood and urine. Stimulation of HCl. Stimulation of HCl by vagus, ACH and related compounds, histamine, gastrin, insulin, caffeine, nicotine, etc. Inhibitors of HCl. Inhibitors of HCl, somatostatin, that is a prostaglandin E2 GI protein, high acidity H2 blockers, atropine. Somatostatin, PGE2, high acidity H2 blockers, atropine. These are inhibitors of HCl. Functions of HCl. Functions of HCl. Bactericidal action due to high acidic media. Bactericidal action due to high acidic media. Activation of inactive pepsinogen to active pepsin. Activation of inactive pepsinogen to active pepsin. Denaturation of proteins. Denaturation of proteins. Iron oxidized to ferric state. Same partial cells secrete intrinsic factor of Castle. Same parietal cells secrete intrinsic factor of Castle. Also absorption of EF is equal to vitamin B12 at ileum. So in organic, there is a mucus. Insoluble or visible mucus. Polymer of glycoprotein. High viscosity. Surface epithelial cells. It is a 0.5 to 2.5 millimeter thick. Protects mucosa from acid pepsin digestion. Soluble mucus. Mucous neck cells. Acts as vehicle for HCl-aligned enzymes from gland to lumen. Intrinsic factor. Secretion of parietal cells. Glycoprotein. Absorption of vitamin B12 at ileum. Deficiency causes pernicious anemia. Stimulation by acetylcholine, gastrin, histamine. Enzymes. Pepsin. Pepsin as a it active. Pepsinogen by chief cells. Activation by HCl. Molecular weight 35,000. Optimum pH 1.5 to 3.5. Stimulated by vagus, acetylcholine, gastrin, insulin, histamine. Then endopeptidase. Peptide linkage to aromatic amino acid are broken. Peptide linkage to aromatic amino acids are broken. End products. Proteoses, peptones, few amino acids. Enzymes is continued. Next, renin in colzine infants. Chief cells with calcium precipitated milk protein. carbonic anhydrase, gelatinase, lipase, urease, and salivary amylase continue to act in stomach for 30 to 60 minutes. Inactivation by gastric acidity. So these are the methods of study of gastric secretion. This Paul's pouch, sham feeding, you are having 3 marks question or 5 marks question. 3 marks or 5 marks. Functions is also 3 marks. Composition is also 3 marks. In this gastric secretion, you will get many short answer and short note. Remember that. In animals and in humans, methods of study of gastric secretion. In animals, pouches, esophagostomy, and sham feeding. Pouches, you can see how the stomach transverse incision in the stomach from lower end. Preparation of Paul's pouch. What that arrow mark is shown? Food inside and it is coming outside. Paul's pouch. Significance. Pure, uncontaminated gastric juice. Pure, uncontaminated gastric juice. Definite fraction of total juice. Each phase study neural and hormonal regulation and interrelationship. Neural and hormonal regulation and interrelationship. Then we will come to the hidden hand pouch. Here vagal denervated pouch. Blood supply intact. Sympathetic supply intact. Next is Beakel's pouch. Beakel's pouch. Denervation of both parasympathetic and sympathetic nerve. Blood supply intact. Next one is feral and IV pouch. Implantation on anterior abdomen. New blood supply. Then fermentous pouch made of entire stomach. One is Paul's pouch, then hidden hand pouch, Beakel's pouch, feral and IV pouch, fermentous pouch. Esophagostomy and sham feeding. Esophagus is cut and ends to exterior. Here, eaten food don't enter stomach. Eaten food don't enter stomach. Comes out through upper esophageal opening. So, sham means false feeding. Sham feeding means false feeding. Cannula in the stomach drains gastric juice. So this gastric secretion increases during sham feeding. It stops by vagotomy. Dependent on intact vagus. Food fed through other esophageal opening. Paul pouch combined to it to study cephalic phase, both conditioned and unconditioned reflexes in gastric secretion. Methods of gastric secretion in animals and in human. In humans, I will tell you some studies. Here, historical medical cases. William Beaumont study on Saint Martin with permanent fistula due to gunshot injury. The permanent fistula due to gunshot injury. Next, wolf and wolf study on Tom Little after gastrostomy due to esophageal stricture caused by hot soup. Gastrostomy due to esophageal stricture caused by hot soup. In humans, method of study, fractional test meal, endoscopy, barium meal, scanning, magnetic resonance imaging, that is a MRI. So regulation is very important. Usually they will ask composition, regulation of gastric secretion and applied physiology. Applied physiology itself is a separate question, it will come. But sometimes they will add a note on peptic ulcer. Composition, regulation, add a note on peptic ulcer. This is a regulation of gastric secretion, continuous. It has got two phases. One is digestive phase, then interdigestive phase, that is a resting or minimal. So this regulation of gastric secretion, digestive phase. Digestive phase, it has got three phases. It got three phases: cephalic phase, gastric phase, intestinal phase. Remember, cephalic phase, gastric phase, intestinal phase. Then neural. In neural and hormonal. Cephalic phase, gastric phase, intestinal phase, and hormonal. So mechanism of gastric secretion. We'll come to the cephalic phase. Before food entry into stomach, reflexes from head end, even sight, smell and thought of food, vagus dependent through acetylcholine and gastrin. Study by esophagostomy and sham feeding. Stimulation by both chief cells and parietal cells. Increases both HCl and pepsin secretion. Gastric phase. Food in stomach. Study by direct placing food in stomach, regulated by both by neural and humoral mechanisms. Interaction augments secretion than individual. Secretes alpha protein content of. It is a diagram showing HCl secretion during different phases of gastric secretion. That is a rate of secretion one side. You can see, sorry. You can see first cephalic phase, then gastric phase, then intestinal phase. This diagram is important. Mechanism of gastric secretion, neural. Stimulus, presence of food, there will be a stretch of mucosa. By long vagovagal reflex and local intrinsic nerve plexus reflex. Humoral, gastrin, acetylcholine and histamine. Action by both independent and synergistic. Gastrin, that is a GI local hormone. By enteral G cells, acute cells. Embryological by neural crest. Stimulus, distension of mucus, partly digested proteins like peptones and amino acids, Inhibition gastric acidity, that is a negative feedback mechanism, multiplies action of vagus, action on both chief and parietal cell, increases HCl pepsin intrinsic factor secretion and increases gastric motility mediated by calcium. Then we will come to the intestinal phase. Entry of acid chyme into duodenum causes decreased gastric secretion and motility, so that small amount of acid chyme undergoes full digestion and absorption at time, and stomach acts as a storage organ for hours after meals. Stimulus peptones and amino acids in duodenum through G cell secretion of gastrin. Intestinal phase, mainly inhibition. You can see the diagram. Humoral acid, amino acids, fatty acids, osmoreceptors in duodenum. On stimulation, there will be a secretion of secretin, CCK-PZ, GIT, bulbogastrin, etc. produced. Inhibit gastrin and parietal cell. Then enterogastric reflex. Food in duodenum, especially fat by local nerve flexes, inhibit. Interdigestive phase or resting minimum. Stimulants of gastric secretion. Histamine, caffeine, alcohol, smoking, parasympathomimetic drugs. Example, acetylcholine, pilocarpine, then calcium, steroidal and non-steroidal drugs, hormones, gastrin, insulin, ACTH and glucocorticoid, motilin, thyroid. Inhibitors of gastric secretion. High acidity, 1% acid in the stomach. Alkalis, example NaHCO3 administration. Parasympatholytic drugs, example atropine. Hormones, CCK-PZ, secretin, bulbogastrin, VIP, GIP, stomatostatin. Effects of emotions. Acute, inhibit, chronic, stimulate. There is a gastric mucosal barrier. Gastric mucosal barrier. It is a GMB. Mucosa vulnerable for acid pepsin digestion. This GMB consists of cell membrane, intercellular tight junctions on surface, thick insoluble mucus of 0.5 to 2.5 mm, secreted by surface mucous cells, HCO3 by mucosa by prostaglandins. Factors supporting GMB. Rate of turnover of mucosal cells, factors neutralizing acid or decreased secretion of HCl, prostaglandins. Factors facilitating destruction of GMB. Regurgitated bile salt. Regurgitated bile salts, alcohol, nicotine, salicylates and drugs, decrease mucus HCO3 and prostaglandin secretion, lysolecithin in regurgitated food, ischemia of gastric mucosa, adrenaline agonists, example adrenaline and noradrenaline by decreased HCO3 secretion. Test for gastric secretion. fractional test will basal acid output, peak acid output after pentagastrin, that is a PAO after insulin. Disorders, just now I have told, applied physiology or disorder itself is a 3 marks question. Number one, all of you know that common word gastritis, hyperchlorhydria, free acid more than 45 milliequivalent per liter, achlorhydria, hyperchlorhydria, peptic ulcer. It is one of the short answer, 3 marks question. Then dumping syndrome, Zollinger-Ellison syndrome, small stomach syndrome. Remember this dumping syndrome, Zollinger-Ellison syndrome, they may also ask as for a 3 marks question. In short, I am telling about peptic ulcer. I am not discussing everything. You just go through. If they will ask, add a note on. If you write this much, that is enough. Definition: localized destruction of gastric or duodenal mucosa due to acid pepsin digestion. There are two types. One is gastric and the other one is duodenal. Causes increased acid and pepsin secretion, continued irritation of mucosa, ischemia of gastric mucosa, infection by Helicobacter pylori, and chronic stress. That is a chronic stress. Physiological principles in treatment of hyperacidity and peptic ulcers. In a tablet form, we can see that we'll give antacids, that you remember. Surgical treatment, vagotomy plus enterectomy, vagotomy plus pyloroplasty, vagotomy plus gastrojejunostomy. Dumping syndrome. Symptoms in this patient with gastrojejunostomy or gastrectomy. Gastrojejunostomy or gastrectomy. Weakness, dizziness, sweating after 2 hours after meals due to hypoglycemia, rapid absorption of glucose and insulin secretion, reduced plasma volume, hypertonic food in intestine draws more water into intestine lumen. Zollinger-Ellison syndrome, gastrinomas, gastrin secretion tumor, example in pancreas, hyperacidity and multiple peptic ulcers, negative feedback control of gastrin by acidity not possible, steatorrhea and diarrhea due to indigestion of fats and protein due to high acidity. Small stomach syndrome or partial gastrectomy, distension and discomfort on food intake, less food intake, that is our weight loss, vomiting, diarrhea and steatorrhea, palpitation and flushing due to hypoglycemia. So this is about your SCL secretion or gastric secretion. I finished. It's a one long question including short note and short answers. Prepare well this question. Just see the previous question paper, how they asked questions. According to that, you prepare this one long question and short note and short answer. Any doubt? Hello? Hello? Can you hear me?
Yes, ma'am. Yes, ma'am.
Aryan, at least respond something. Say yes or no. You have any doubt?
No, ma'am.
Understood at least something?
Yes, ma'am. Yes, ma'am.
Can you write if you will get this question?
Yes, ma'am.
Yes, you will prepare on question on this answer.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Good morning.
Hey, good morning.
Madam here.
Okay. Ayo, I am thinking here. यहाँ से आ रहा है.
बहुत अच्छा बोला. मैं heard since 15 minutes से सुन रहा हूँ.
हाँ.
अच्छा बोला.
सही है.
तो अच्छा बोला. नहीं मैं देखा ना देख के बोल रहा हूँ. मेरा एक क्लास है वही anatomy स्टमक.
हाँ मैं समझ के लिए देखो.
वही देखा मैं.
अच्छा हुआ.
मेरा लगा है.
अच्छा होता है समझ में आया.
आज क्या हुआ 2 दिन के बाद सर मिले आपके. क्लास पे 9 बजे. अच्छी तरह बात करें डोंट वरी बोले. मैं बोला भाई आईसीयू में है 2 लाख सुजाता 2 लाख बिल हुआ है. 1,30,000 का सिर्फ इंजेक्शन हुआ है. रेमडेसिविर, बेविसिलिमाइड एंड कोलिस्टिन. कोलिस्टिन पर डोज 11,000 5 days 55,000 इटली. सो अराउंड 2 लाख रुपीस बिल हुआ है. तो उन्होंने सर क्या काम करते हैं तो तैयार नहीं.
साथ में
नहीं ओन प्रोडक्ट के लिए नहीं बोलते हैं खाली डिपेंडेंट बोलते हैं.
कैसा?
लता को कुछ तकलीफ हुआ एडमिट थी.
मुझे भी कल पता चला है उसको फोन करना नहीं हुआ मुझे.
नहीं क्या एंटीबायोटिक सपोर्ट के लिए आई थी क्या डी डाइमर हाई हुआ था पता नहीं.
कुछ बोल के आई थी.
अच्छा हाँ.
अभी है क्या गई?
शायद कल गई बोल के सुना मैं शाम में एम ब्लॉक गया था मैं.
हाँ.
तो स्टाफ बोले ये ले सर ये और मनी ये करके बोले.
वो एडमिट है बोले मंजुनाथ सर मुझे.
अच्छा हाँ कोई एडमिट था एम ब्लॉक में. आप ठीक है ना?
नहीं मुझे कल ही पता चला है दोपहर में.
आपकी तबीयत ठीक है ना?
मैं ठीक हूँ.
सर को बोलो थैंक्स करना. ये सब क्राइसिस होने के बाद बात करेंगे. हाँ
श्योर
प्लीज. हाँ मैं क्लास लेता हूँ टाइम हो रहा है.
हाँ इधर लेते हो क्या?
रेडी किया हूँ बाजू में.
ओके. ಅದೊಂದು ಸ್ವಲ್ಪ ಏನಾದ್ರು ನೀವು ಮಾಡ್ಕೊಡ್ತೀರಿ?
ಅದೇ ಆನಂದ್ ಸರ್ ಅಲ್ಲಿ ಇದ್ರಾಗ ಬಿಜಿ ಪೀಡಿಯಾಟ್ರಿಕ್ಸ್ ಇದ್ರಾಗ ಬಿಜಿ ಇದಾರೆ. ನಿಮ್ಗೆ ಕಾಲ್ ಮಾಡ್ತೀನಿ ಮೇಡಮ್.
ನಾನು ಕಾಲ್ ಮಾಡ್ತೀನಿ.
ಹಾಂ ಕಾಲ್ ಮಾಡಿ ರಿಸಲ್ವ್ ಮಾಡ್ತಾರೆ.